Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has companion articles number 18, 28, and 29. Welcome to the Pain is Not the Only Problem podcast. Articles 18, 28, and 29. Pain is not the only problem. Diagnosis Parts 1, 2, and 3. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Article 18, Diagnosis Part 1. Diagnosis equals evidence. Consider these three divisions of clinical diagnosis: diagnostic possibility, diagnostic probability, and diagnostic pathology. If a diagnosis is provided by a top surgeon, the patient will get a surgically related diagnosis. If the patient's diagnosed by a top sports chiropractor, the patient will get a motor function related diagnosis. Optimally, these various diagnoses from various physicians should land sufficiently on the same dime, but this is rare. Physicians with specific backgrounds and expertise commonly practice within their wheelhouse. Physicians should be practicing across cultures instead of battling it out to prove themselves right. This causes confusion and problems for the patient when they seek out options or second opinions. Medicine is not a territory to defend. First, let's look at diagnostic possibility. Diagnostic possibility offers no direct proof and is not compelling. Diagnostic possibility is described as chance, feasible, potential, conceivable, might, or the doctor may say, hey, I bet it's this or that. Diagnostic possibility is reductionist. It makes no effort to rule out other diagnoses and only addresses symptoms such as pain. Diagnostic possibility commonly includes theoretical explanations such as a pinched nerve, disc herniation, disc degeneration, subluxation, cord compression. Diagnostic possibility does not offer any other multi-system explanations or comorbidities and does not offer anything related to chemistry within the body, the neurology, the immunology, any type of social contributions, economic contributions like loss of job or job dissatisfaction, motor dysfunction or motor function for that matter. Diagnostic possibility offers the weakest treatment plan since no known cause is understood. It is the cookbook approach, based mainly on practice bias for whatever reason, and it's equal to kicking the tires without looking under the hood when you buy a car. Ebel 2019 says it like this: making a conscientious effort to base clinical decisions on research that is most likely to be free from bias and using interventions most likely to improve how long or how well the patient lives. Now let's look at diagnostic probability. Diagnostic probability offers some direct and convincing proof. Diagnostic probability is described as likely, reasonable, expected, but it can also be uncertain. Diagnostic probability is based on findings related to symptoms, imaging, labs, tests, etc., and attempts to use these findings to explain the symptoms. They rarely explain the problem. Yet the multi-system explanations are still absent. Diagnostic probability considers patient presentation with a commonality or frequency within the population. For example, doctor may have seen this type of complaint 15, 20, 100, 500 times. And they say, hey, I've seen this a bunch of times, similar presentation, and it tended to be this type of diagnosis. Diagnostic probability offers a more specific treatment plan, but this can be dangerous if surgery is recommended since the diagnosis is still presumed and not proven. It is equal to looking under the hood of the car without turning on the engine. Now let's look at diagnostic pathology. Diagnostic pathology offers direct and compelling proof by identifying all the lesions, specific lesions included, disease or motor function insufficiencies, and offers a variety of working and differential diagnosis. Diagnostic pathology considers the input from all physicians on the patient's team. Hopefully, the patient has a team. Diagnostic pathology is evidence-based, identifies current best practices, and includes a complete multi-system explanation. The whole patient approach, as described by Dean 2016 and Fardon et al. In 2014. Diagnostic pathology can treat the problem directly since it is very well understood by the physician, the physician's team, the patient's team, and by research. It is equal to turning on the engine and taking the car out for a spin when you buy a car. To be fair to the discipline, clinical decision-making can involve complicated statistical analysis, significance, p-value, prevalence, specificity, sensitivity, probability, and the like. Right? However, the clinician's attention may produce better outcomes by taking a new look at low back pain diagnosing as recommended within these articles. Let's look at the definition of diagnosis, which is provided to us by Dean 2016. Diagnosis definition: the way the physician characterizes the most complete and likely explanation to describe and explain the complex of problems and symptoms being experienced by the patient. Let's read that again. Diagnosis definition: the way the physician characterizes the most complete and likely explanation to describe and explain the complex of problems and symptoms being experienced by the patient. Now let's look at the definition of diagnostic evidence, also provided to us by Dean 2016. Diagnostic evidence: credible, robust, expert articles that argue in favor of a diagnosis without personal bias or attitudes nor plausibility. The physician does not assert a professional opinion that certain objective findings could, in theory and without other prevailing evidence, support a rationale to conclude one specific diagnosis. All diagnoses are considered working diagnosis, differential diagnosis, and complete diagnosis. And we're not talking about one single diagnosis. Complete diagnosis means that the physician has charted all of the patient's medical conditions, currently presenting and historical, and from the problem list. The number one comorbidity to low back pain is smoking. So this should be included in the charts if the patient is a smoker. Z72.0 tobacco use or Z77.22 secondhand smoke exposure. And of course, a treatment plan absolutely must be prescribed and cannot be overlooked. How does the diagnostic process work in your office? Do you have a list of favorite diagnostic codes? How many diagnostic system codes do you commonly chart? We're talking about systems, not diagnosis specifically. So I'm not talking about back pain plus spasm plus motor function dysfunction, let's say somatic and segmental dysfunction. I'm talking about systems. There are 19 systems in the body. Are you diagnosing cardiac or pulmonary or immunological or mental systems? How many total diagnostic codes do you chart for your average low back pain? 1, 2, 3, 5? In my office, it's commonly 10 or more. What kind of evidence do you use to evaluate your low back pain patients? Are you doing common orthopedic exams that most people don't even understand why they're using them or the value, sensitivity, and specificity? Or are you always just jumping first to plain film? How much evidence do you gather for your final diagnosis? And is all of that a routine? Do you chart and code anything, everything from the patient's problem list? Do you even look at the patient's problem list? I mean, if they've been smoking for 1 year, 5 years, 10 years, and they have back pain, you need to discuss with them that correlation because it's important. Do you chart anything that's not low back pain related? For example, Z71.1, fear due to being undiagnosed. Are you charting pain as the primary diagnosis? Do you ask the patient for their ideas about their own low back pain? Globe et al. 2015 says this: in all cases, a diagnosis should never be made only because the physician offers a treatment plan for it or exclusively to determine a need for care. Acquiring diagnostic evidence takes time, but not much more time than a thorough history. How long does a thorough history take? 5 to 9 minutes. And 90% of the diagnosis is in that history. And if you let the patient talk, they're going to tell you exactly what the cause is. And the clinician is already being paid to take the history, so this should not be a problem. Clinicians' diagnostic habits and protocols may be oversimplifying the diagnosis as only pain. However, pain's not the only problem. Sometimes it's the clinician's habits towards diagnosing that's the problem. Article 28. Diagnosis, Part 2. Diagnosing is not something that the clinician performs in order to complete an insurance form or to push their paperwork forward. It is not the act of assigning ICD codes. It's not a technicality. Diagnosing is not simply disclosing the name of the problem to the patient, and it is certainly not describing what the patient has wrong with them or what they have. Don't use your diagnosis to blame the patient. Diagnosing is not pointing to a chart or to a picture with a pencil eraser and placing blame. Please don't blame the patient. However, this is the common practice in modern industrialized medicine. Communicating the diagnosis fails to deliver much more than checking a box within the algorithm of insurance-based low back pain case management. Diagnosing is much more than matching the history and the findings with an accurate description of the patient or the athlete's problem. Diagnosing should expose and explain the experience of the entire patient with a sound medical explanation, one that they understand. In all cases, the clinician should be including diagnostic explanations that include social aspects, economic aspects, cultural and personal aspects, developmental aspects, conditional aspects, religious and environmental. Yes, you need to go there. You must go there. It will only take a minute and a half to demonstrate to your patient that you aren't just pointing to their anatomy and blaming a dysfunction of their anatomy or a reaction of their anatomy, inflammation, spasm, whatever. All of these explanations must be included. A diagnosis of low back pain, M54.5 with back spasm, M62.830, is incomplete. A complete diagnosis must include, for example, lack of exercise, Z72.3, emotional stress with muscle tension, F43.8, hostile work environment, right? There's that job dissatisfaction, Z56.5, insufficient sleep, F52.12. We know that contributes to low back pain. Housing problems or housing insecurity, Z59.9, and social fears, F40.10. The complete diagnosis explains the entire patient, not just the symptom or the symptoms, and not specifically and only their low back pain. Diagnosis definition: the way the physician characterizes the most complete and likely explanation to describe and explain the complex of problems and symptoms being experienced by the patient. In other words, the diagnosis should be teaching the patient something they don't already know. I say this all the time. When I am the second opinion, or I am the second or third or fourth or 10th doctor that my patient has seen, and I say to them, what is your diagnosis to date? What do you understand about characterization of what's happening with you? What has another doctor said to you that's your problem or what's wrong? And they say I have back pain. Okay, well, didn't you already know that? Yeah, I already knew that. Well, then why did you pay the doctor to tell you already had back pain when you already knew you had back pain? You want the doctor to actually tell you something you don't already know, right? The doctor is the expert. So then the patient gets upset, but that doesn't matter because that all gets corrected the same day in my office. A diagnosis of back pain, M54.5, does not teach the patient anything new. However, the clinician can teach the patient about the well-documented correlation between, for example, job dissatisfaction, Z56.6, and low back pain. That's the second commonest cause. And how her fears about income insecurity if she loses her job, Z56.2, and keep her awake at night, Z72.820, are influencing her back pain. You have to open up the aperture. You have to zoom out. Since she is not getting enough exercise, E72.3, and has gained weight, E66.3, she feels stress, F43.8, and is avoiding family functions due to social embarrassment, F40.10, that is also contributing to her back pain. It's a spectrum. She's an entire person. She is an entire patient. You can't just focus on the back pain. Everything I just mentioned are the top contributors to back pain. So why aren't those being addressed by the doctor? Who else is going to address them other than the doctor? No one. The relevancy of the diagnosis to the entire patient builds a complete clinical picture that educates the patient. The diagnosis becomes the platform for a course of care to address the entire patient. Obviously, pain is not the only problem when diagnosing the entire patient. A complete diagnosis reassures the patient or the athlete that the clinician's heart and toolbox are vast. Article 29, Diagnosis, Part 3. Clinically, the requirement to diagnose can be an administrative headache. It would be easier to skip the process altogether and move on to the treatment, since the patient isn't usually interested in the diagnosis anyway. A diagnosis of back pain, sciatica, lumbago, disc disorder, piriformis syndrome, is a generalized superficial diagnosis that suits the requirement of diagnosis, although it rarely characterizes the more important underlying problems and certainly doesn't explain the entire patient. A diagnosis must completely explain the entire patient, not simply the experience of discomfort. The diagnosis should primarily explain ADL insufficiencies, sports activity deficits, hobby and leisure obstacles, and other struggles with usual enjoyment and mental wellness. Do you understand? The diagnosis should not be an offhanded guess, a shortcut to begin treatment. The diagnosis must describe a real biological or biomechanical problem based on scientific research, not based on doctor popularity or clinician popularity, such as piriformis syndrome or sciatica, or anything with a fancy name that's impressive to the patient. Ankylosing spondylitis. The diagnosis should not be an oversimplified attempt to explain the complexity of the patient's experience. Instead, it should describe the symptoms, ADL insufficiency, employment problems, inability to do sports, hobbies, daily enjoyment, emotionality, or organic and experiential emotionality, and of course, paying attention to personal values and expectations. This is not a tall order. The diagnosis should include contributions to lifestyle choice and circumstances. Lifestyle choices and circumstances should be addressed by the clinician during the explanation of the diagnosis so the patient understands the influence of these connections. For example, job dissatisfaction or the inability to sleep. A diagnosis of sciatica might explain the symptoms, but it does not address the cause for the distribution of the pain down the back of the leg. Simply blaming a pinched nerve is not scientific, nor is it accurate. A diagnosis that only addresses pain is borderline malpractice. The diagnosis should never be used exclusively to determine a need for care. Instead, the diagnosis should define the course of care to resolve the complex patient experience. It should address the symptoms. It should address reestablishing ADLs and minimize further disability. It should address the return to work, the accessibility to sports, hobbies, daily enjoyment. It should address improving outlook and emotionality, especially depression. And it should address minimizing further disability and fear of reoccurrence. And of course, it should provide excellence in patient outcomes and satisfaction. The action of diagnosing must address the insufficiencies of the patient and the clinician. They both have insufficiencies. Patient insufficiencies include these: habituation, which has no cognitive mapping, right? This is just like they say, oh, I'm too lazy. It's not based on decision making. It's based on habituation. Or ambivalence, right? Also, there's no cognitive mapping. Here it's just doubting, right? So without making a decision about their care, they say, oh, it'll pass, right? So another reason, an insufficiency not to address care for their low back pain. Or exemption, which also includes no cognitive mapping, right? Denial. Denial's not a choice. It's automatic pilot, right? They may say, oh, it won't happen to me. Oh, it won't get worse. That's somebody else. It'll pass. I'm too lazy, right? No cognitive mapping. Now let's talk about cognitive mapping in the insufficiencies of the patient. Preference. This does include cognitive mapping because it includes biases and convenience, right? They may say, therapy is too much trouble, right? It's too far to go. It takes too much time and I don't trust it. It has cognitive mapping. And then there's reference, which also includes cognitive mapping. This is pattern copying or, the non-professional approach, right? The patient says, I'll figure it out for myself, which is a reason to neglect acquiring a diagnosis or care. So the insufficiencies of the patient are the language, the statements, the beliefs, cognitive and not cognitive, that contribute to not getting a diagnosis. And then the same is true clinically. There are clinical insufficiencies, absent final or working diagnosis. And we're not talking about one final diagnosis or one working diagnosis. We're talking about a group of diagnoses that describe the entire patient, or wrong or incomplete final or working diagnosis. So what I mean here is there are no diagnoses from the problem list. There are no diagnoses from the remainder of the patient's body or their experience or their emotionality or their lifestyle contributions. It's just a diagnosis based on low back pain and absent differential diagnosis. So there are no other diagnoses considered, only the diagnosis of the low back pain when there could be other contributions. And then there are absent differential diagnosis. So the diagnosis of low back pain is just floating out there on an island by itself when other problems could be organic. It could be about the bowel. It could be about lifestyle habits like chronic crossing of the legs or chronic sitting or lower cross syndrome, even upper cross syndrome, right? So these other diagnoses have to be, as differential diagnosis, must be considered, but typically this is a clinical insufficiency. And then there's absent patient education and report of findings. Who does a report of findings? I do a report of findings, but I don't know any other doctor that does a report of findings. They've only said, so your diagnosis is back pain, but I already knew that, and they don't have anything else to offer. And I'm not getting any of the details of the report of findings. And you can go to Article 30 or podcasts that relates to Article 30, and you can learn about report of findings. And then there's absent management plan or course of care. So the course of care is reduced down to an injection or to physical therapy. But that's not management because it doesn't address what you're going to do when something doesn't work or the expected outcomes are not delivered to the patient or the patient isn't experiencing the results that they expect. There's nothing else already set up. So the doctor waits until the whole thing falls apart and then they try to resurrect the patient's care, but there's no plan. So the plan should always include what to do when it goes wrong or when the expected outcomes aren't delivered. And then, of course, there's the wrong or incomplete management plan and course of care. A clinician that begins treatment without a complete diagnosis, we talked about this, everything that has been explained to the patient in a report of findings, is in every violation of medical care. Clinical insufficiencies are devastating to case management since referral and treatment interventions are prescribed without the foundational support of a complete diagnosis. Gold standards are overlooked since science is ignored, current research is unincorporated, conservatism is overlooked, and yet patient care proceeds. 85% of low back pain patients experience depression, according to Sheng et al. 2017. A diagnosis of low back pain without a diagnosis of depression does not completely address the patient experience and does not incorporate a course of care to manage the patient's depression. The diagnosis must describe every real biological or biomechanical problem based on scientific research, not just pain, because pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-culture willingness to strengthen medicine. Thank you.